Guys, good morning. I hope you are doing fine. Today, I will start discussing a very important topic, which is falls. So, in Lab 2, you can have a station where the patient will come to you and the presenting complaint is fall. Fall. The patient had a fall. So before I start discussing fall stations, I would like you to know, if a patient is presented with a fall, history of a fall, do you think it is medical or counseling? Do you think this station will follow medicine structure or counseling structure? I always say counseling structure, which means a station is diagnosed, a patient is diagnosed. But medicine structure, a patient that there is no diagnosis yet and it's your job to diagnose. So if a patient is coming to you, how can I help you? Doctor, I had a fall. So I will follow the medicine structure. P1 is a fall. So how can I help you, doctor? I had a fall. I had a fall. Okay? So sympathy and empathy, a patient who had a fall. Well, I'm really sorry about that. Can you please tell me more about it? Can you please tell me more about it? Can you tell me more? Open question. Can you tell me more about the fall? So what more do you need to know about the fall? Always when I explore the fall as a presenting complaint, I will use before, during, after. So before, during, after. So that's what I will use to explore the fall. Before the fall, during the fall, after the fall. Before, during, after. So before the fall, what do you want to know about before the fall? Did you lose your consciousness? Did you lose your consciousness? Very important question. Did you have any heart racing? Any heart racing? Did you feel dizzy? Did you feel dizzy? Did you have any fit? Any fit before the fall? And how was your diet? Which means hypoglycemic fall, a patient who have or who has hypoglycemia, a patient who felt dizzy, then had a fall because of hypoglycemic fall. So 5 questions before the fall. So before the fall, did you lose your consciousness? What happened just before you had the fall? Did you lose your consciousness? Did you have any dizziness? Did you have any heart racing before the fall? So heart racing, then fall, which is AF, loss of consciousness, heart racing, dizziness before fall, and how was your meal? Or did you have your meals regularly? Or did you have your regular meal before the fall and any fits before the fall? So how many questions before the fall? Loss of consciousness before the fall? Did you feel dizzy before the fall? Did you have heart racing before the fall? And your meal before the fall? Did you have a fit just before the fall? Fit before the fall, epilepsy, trying to achieve epilepsy, then fall. Your meals regularly before the fall, hypoglycemic fall. Heart racing, AF. So heart racing, then fall, because AF can lead to dizziness. Dizziness before the fall, loss of consciousness before the fall. So exploring what happened before the fall will give you an idea about the differentials. So these are differentials for fall. Okay, during the fall. During the fall is when you had the fall. Did you bite your tongue? Did you wet yourself? I'm sorry to ask you these questions, so always signposts if there is something that quite intrusive. Did you have a fit during the fall? Did you bite your tongue? Did you wet yourself? I'm asking about epileptic kind of fall. Epilepsy and then fall. So during the fall, did you bite your tongue? Did you wet yourself? Did you have any fits during the fall? Okay, after the fall. After the fall, what happened? Again, after the fall, you can ask about fit, bite tongue, wet yourself. So you can say, did you wet yourself or bite your tongue during or after the fall? So during and after the fall, bite tongue again, wet yourself, or fit during and after the fall. And don't forget the first logic question, when did you have the fall? Okay, so please, if you have a patient who's coming with a fall, this is medicine structure. P1, P2, P3 مفتوز. So P1, how can I help you? I have a fall, doctor. I had a fall. Well, I'm really sorry about that. Can you please tell me more about it? Tell me more about it. What do you want to know, doctor? During, before, after. First of all, when did you have the fall? During or after the fall? Did you bite your tongue? Did you hit yourself? Did you have any fits? What about before the fall? Just before the fall. Did you lose your consciousness? Did you feel dizzy? Did you have any heart racing? How was your meal? Did you have your meal regularly before the fall? And did you have any fit before the fall? So these are the questions that you ask before, during, after to explore the fall. Okay? So after that, anything else apart from the fall? So the next question, anything else as we go back to day one in the course? Anything else? If he tells you something else, explore. And at the end, concern. What's your main worry? Or what's your main concern? What's your main concern? What's your main worry? So always in PLAB 2, you need to ask every and each patient concern, main concern. In PLAB 2, in every and each single station, you need to ask your patient, what's your main worry? What's your main concern? And after that, I will go to my differentials. What are the differentials? What are the causes of the fall? So the differentials or the causes of the fall, I will split them, the differentials or the causes of the fall, what can make the patient fall, into non-medical and medical. Non-medical and the medical causes of fall. What do you mean, Dr. Mo, non-medical and medical causes of fall? Non-medical, nothing to do with medicine, basically. Medical is medicine. In the medical, I will divide them into causes that might not lead to no loss of consciousness, negative loss of consciousness, and the causes that can lead to positive loss of consciousness. So, causes of fall, differentials of falls, causes of falls, the question that I will start asking my patient, non-medical and medical, medical without loss of consciousness, or medical with loss of consciousness. So non-medical causes, what can be non-medical causes? Slipping, yes. Tripping, yes. The light is not good and then he had a fall, yes. He got pushed, which is very common cause of falls in elderly. NAI, non-accidental injury, if somebody pushed him or her, can lead to a fall. And finally is alcohol. So the non-medical causes of fall: slipping, number 1, tripping, number 2. So slipping, tripping, light, if the light was not good enough, number 3. Number 4, if somebody pushed him or her, so has he been pushed? So in brackets, NAI, non-accidental injury. Non-accidental injury. So very important cause of fall in elderly is non-accidental injury, if you push someone, okay? And finally, alcohol. If this patient has been drunk, alcohol, and then he can have a fall. So slipping, tripping, light, if somebody pushed him or her, alcohol. The medical causes of fall. The medical causes of fall, which means things to do with medicine, which means I will ask the patient, have you lost the consciousness or not? And depending, I will have the causes. Have you noticed before the fall? What do I ask? Loss of consciousness. Loss of consciousness. So here, medical, if there is loss of consciousness, what can I think of? I can think of 1, 2 hypo. 2 in the heart. Epilepsy and vasovagal syncope. Vasovagal syncope. So the medical causes of fall, I will divide them into, is there a loss of consciousness or is there no loss of consciousness? If there is loss of consciousness, 2 hypo, 2 in the heart, epilepsy, vasovagal syncope. 2 hypo, which is hypoglycemia, and postural hypotension. What do you mean, Dr. Mo? Hypoglycemia. If I'm asking the patient just before the fall, did you have your meals regularly? He said, no, doctor. No, I didn't. And later on in the structure, because all this is in P1, still we have not reached P2 yet. When I go to P2, I will ask the patient any medical condition. He will say, I'm diabetic. Are you compliant with your medication? I will say, yeah, well, I'm taking them, but I'm not really having a meal properly. So then when you reach hypoglycemic fall, and when you ask him just before the fall what happened, he will give you a story of having the medication, the insulin, but not eating, hypoglycemic fall. And he will tell you, I felt hungry, irritable, sweating, symptoms of hypoglycemia. So the patient will have with the fall, symptoms of hypoglycemia. Okay. The second is postural hypotension. In this case, the patient will have high blood pressure and on medication that led to low blood pressure. So if the patient is hypertensive and he's taking overdose of medication, that can lead to hypotension, postural hypotension. So in the history, in the medical condition, the patient will tell you, doctor, I have high blood pressure and I'm on medication and I have not been for the review or follow-up. Then he's having this. Or when you tell him what happened, exactly he'll say, well, I was suddenly waking up of bed. So postural hypotension when the patient suddenly get out of bed or he's sitting and standing all of a sudden. Two in the heart, either low heart rate or high heart rate. High heart rate, AF. Low heart rate, a condition called Stuck-Adams syndrome. So high heart rate, AF. If I ask the patient just before the fall what happened, doctor, I felt that my heart is racing. I felt that I was hearing my heart beat, AF. Or when I ask him any medical condition, yes, doctor, I am diagnosed AF. Low heart rate, which is the opposite of high heart rate, AF, Stuck-Adams syndrome. Stuck-Adams syndrome is bradycardia that can lead to dizziness and fall. But in the exam, if you have a patient who's having a fall, when you explore about the fall and you ask about any other symptoms, he starts giving you heart problem or whatever, or you feel that from the history or from the examination the heart rate is low, you should not give Stuck-Adams syndrome as a diagnosis, because in BLAP2 in 8 minutes you cannot diagnose Stuck-Adams. But you can say, I'm suspecting a condition that in your heart rhythm that can lead to dizziness. Don't mention the word Stuck-Adams, because that means that you know the station from before, which it's not the case, okay? Epilepsy, because Stuck-Adams syndrome takes about 2-3 weeks to diagnose. Epilepsy. Epilepsy is a cause of fall when there is loss of consciousness. How do I know? Bite your tongue, wet yourself, fit before or during or after the fall. So how would I know? Just before the fall what happened, and during the fall or after the fall. Did you bite your tongue? Yes, doctor, I woke up and I found that my tongue injuries and I bite my tongue, I wet myself and I had fits. So that's epilepsy. So epilepsy, the patient will say that he bite his tongue, wet himself, or fit. And finally, vasovagal syncope, which is, have you seen anything or smell anything unpleasant? So seen or smell unpleasant thing, so that's a vasovagal syncope. Then come to the medical causes of fall, where there is no loss of consciousness. Where there is no loss of consciousness, medical causes of fall, where there is no loss of consciousness, the cause will be either in the ear or in the head. In the head, stroke and mini stroke. Stroke, mini stroke, TIA, which is TIA, stroke, mini stroke or TIA, and even, okay, in the ear, BBBV, benign, paroxysmal, positional, vertigo, okay, and Meniere and vestibular neuritis. Vestibular neuritis. So the medical causes of fall, where there is no loss of consciousness, ear or head. In the ear, I have benign, paroxysmal, positional vertigo, in which, again, the patient will present with fall. When you ask during or before or after the fall, what happened? The patient will tell you, I suddenly moved my head, because it's called benign, paroxysmal, positional vertigo. Benign, paroxysmal, positional vertigo, related to position. So that's why he will tell you. Meniere, or vestibular neuritis. I will discuss them in a bit. Or in the head, stroke, mini stroke, which is TIA, and acoustic neuroma. Okay, that's the in the head. Okay, so stroke and mini stroke. Okay, so these are the causes, differential. Let's finish the rest of the history. However, I am just gonna turn this. So when I give you a good quick revision, okay, you know what's happening. I will use both boards to just show you the whole structure. Okay, so after P1, and after differentials, I have P2, I have P3, I have Maphtosa. So P2, P3, Maphtosa. What is P2? P2 is two questions. Past history of presenting complaint, past history of presenting complaint, and past medical conditions. Past medical conditions. What do you mean past history of presenting complaint? Which means, have you had this fall before? Past history of the complaint that he's having. Fall? Have you had this fall before? If he said yes, I had this fall before, explore. Past medical conditions. Past medical conditions, so do you have any healthy issues? And do I need to ask these conditions? Yes. Why, Dr. Mo? Because there are 5 conditions that I must ask, because when I ask them, it will go under my differentials. Past medical condition like what? Like high blood pressure, diabetes, cholesterol, heart problem, stroke and mini stroke, and finally thyroid. Dr. Mo, the 5 questions: high blood pressure, diabetes, cholesterol, heart problems, stroke, mini stroke, thyroid. Hypertension, high blood pressure. Why? Because in the case of postural hypotension, the patient will be diagnosed with high blood pressure and he will be on medication, and then that's why he's developing hypotension. Diabetes, in the hypoglycemic kind of fall, hypoglycemia kind of fall, the patient will tell you, I have past history of diabetes. Cholesterol, heart, in the patient who have fall due to AF or bradycardia, Stock-Adams syndrome, the patient will have heart problem. Stroke, mini stroke, it is the causes of the fall, negative loss of consciousness in the head. Go back to my previous structure, the other page. Thyroid is the most common cause of AF, and AF can lead to fall. That's why I must ask these 5 medical conditions. P3, which is DESA. P3, which is DESA, diet, exercise, smoking, alcohol. And for me, is important smoking and alcohol. Why? Because alcohol, as I told you, alcohol is one of the causes of the fall. The patient got drunk and then he had a fall. The non-medical causes. Smoking, maybe the patient is using any recreational drugs. Smoking, maybe he is using what? Recreational drugs. So smoking and alcohol. Come to Maphtosa. M is for medication. It's important. Are you on any medication? Why, Dr. Mo? Because the patient can be on medication and the side effect of this medication is fall or dizziness. Like what? Like bendrofluorothiazide. This medication is a medication that I use to treat the hypertension, and the side effect is postural hypotension. So, are you on any medication? So the patient can give you, yes, doctor, I am in bendrofluorothiazide. So now you know what side effect of medication. Any allergy to anything, any family history of anything, travel, occupational, social, anything else. So you don't need the travel, you don't need the occupation, you don't need, and you need social. Social, I will need. Who do you live with? Okay? Who do you live with? How's things at home? Why do I need to ask who do you live with? How's things at home? Because I said NAI is one of the causes, non-accidental injury. The patient may be like had a fall because of she or he got pushed. Non-accidental injury. So how's things at home? And you can even ask about the occupation. If the cause of the fall is epilepsy, if the cause of the fall is AF, if the cause of the fall or the dizziness, something chronic, hypoglycemia, you can ask about occupation, because if the patient is a taxi driver or if the patient working as a driver or working near heavy object, you can give him sick notes and you can tell him you are not allowed to drive. You should tell the DVLA, you should inform the DVLA. DVLA is the driving agency in UK that in charge of anything is to driving. Okay, DVLA, DVLA. Okay, driving and vehicle licensing agency. All right, you inform them if the patient is having a condition to do with driving. Anyway, so this is the history. After the history, what should I do? After the history, I should verbalize examination. After the history, I should verbalize examination. And when I verbalize examination, what do you need to examine in any case of fall? In any case of fall, I will need to examine observations plus chest. Why observation? Because when I check the observation, I'm looking for blood pressure. Why? To exclude postural hypotension. So in examinations, I will verbalize in all cases of fall, observation and chest. Why observation? Because I need to check the blood pressure, lying as well as standing. So the blood pressure lying and the standing should be checked. Why? Because the difference will be more than 20 in the systolic or more than 10 diastolic. So I must check the blood pressure lying and standing in two positions. When the patient is lying down and when the patient is standing, two positions. And the blood pressure difference, when I ask the patient when I measure the blood pressure when the patient is lying down and then when the patient is standing, if I check the systolic, the difference will be 20, diastolic difference will be more than 10. So more than 20 systolic, more than 10 diastolic, postural hypotension. Chest, why? The heart. Why the heart? Heart rate, is it high, AF, is it low, bradycardia. After the examination, I will go to provisional diagnosis. But don't forget that before provisional diagnosis, we ask the patient about ideas. Do you have any ideas what's happening? Do you have any idea what's going on? Do you have any idea the reason why you are having these falls? Okay? Then I will go to provisional diagnosis, and the provisional diagnosis will be according to the case, which means I will speak in a simple language, in a very simple language, and explain to the patient about his condition. Well, for example, if it's a postural hypotension, from the information you have given me, according to my examination, I'm suspecting that the reason why you are having a fall is because there is a difference in your blood pressure when you're lying and when you're standing. So when you stand up suddenly, the blood pressure suddenly drop, which leads to dizziness and fall. If I'm telling the patient about AF, so it's a condition of your heart where your heart is beating fast. Simple. After that, I will go to management. And in management, don't forget what? 7 steps. 7 steps in management. So in management, I have 7 steps in management. Don't forget in management, the 7 steps, we know them from day one. But I will just focus on the investigation. What are the investigations that I will do in each and every case? You remember the investigations, step 3 investigations. In investigation, I said in any investigation mention, blood, urine, stool, image. I don't need urine, I don't need stool, I just need blood and image. So in the blood and in the image, what do I need to mention? What do I have to mention in each and every case of fall? In the blood, can anemia lead to dizziness? Yes, doctor, on fall. So, full blood count. Can blood sugar leads to any kind of fall? Yes, hypoglycemia. So, blood sugar. So, random blood sugar. So, full blood count and blood sugar, as simple as that. You must check in every and each patient, full blood count and blood sugar. Guys, I mentioned all kind of bloods like thyroid function test, because it's a cause of AF. So full blood count, blood sugar, thyroid function test, must be mentioned in every and each case of fall, plus anything else you want, but mainly full blood count anemia, blood sugar hypoglycemia, thyroid function test. Images ECG, images ECG, images ECG, images ECG, images ECG. Then manage the factor, manage the factor, manage the factor. That's according to the case. So according to your case, you will manage the factor. Okay. So again, quick recap to my structure of the fall. Quick recap to my structure of the fall. If a patient is coming with a fall, presenting complaint is a fall, can you please tell me more about it? You need to know before, during, after. Before, loss of consciousness, dizziness, heart racing, meals, fit, during and after. Did you bite your tongue, wet yourself, have a fit? Concern, DDs, non-medical and medical, non-medical, slipping, tripping, lightning, pushed in the eye, alcohol, medical, positive and negative. Positive what? Positive loss of consciousness, negative loss of consciousness. If there is positive loss of consciousness, too hypo, too hard, epilepsy, vasovagal syncope, too hypo, hypoglycemia, hypotension, postural hypotension, too hard, high, low, high AF, low Stock-Adams syndrome, epilepsy and vasovagal syncope, negative loss of consciousness, ear and head stroke, mini stroke, ears, PPPV, Meniere, and vestibular neuritis. Come back to the second part, which is P2, past history of presenting complaint, past medical condition. You must ask the 5 conditions. P3, DESA, smoking and alcohol, Maftosa, medication, occupation, social. Examination, every and each case, check the observation, blood pressure, heart, high or low, provisional diagnosis, management 7 steps. In the 7 steps, make sure you mention investigations like bloods, blood that must be done, full blood count, blood sugar, thyroid, imaging such as ECG, and then manage the case accordingly. Now, let's discuss okay, I shouldn't have wiped this really, but anyway, let's go back here and discuss a case one by one, cases of fall. Okay, first case is postural hypotension case. 64 years old lady presented with a complaint of fall a few weeks ago. In this case, they will give you in the cubicle, they will give you in the question, blood pressure was measured standing, blood pressure measurement lying down, and the difference will be more than 20 systolic or more than 10 diastolic. That will be given in that question. However, if it's not given, it's fine. So how can I help you? Doctor, I had a fall. I'm really sorry about that. Can you please tell me more about it? What do you know? What do you want to know, doctor? Just before the fall, anything significant happened. Like what, doctor? Loss of consciousness, dizziness, heart racing, meal, fit, everything will be negative. She will tell you no. I just felt a bit dizzy. That's what she will tell you. Dizzy before. During or after the fall, did you bite your tongue? Did you wet yourself? Did you have a fit? No, doctor. Before the fall, what happened? The positive finding will be I felt dizzy and I suddenly go out of bed. Or I felt dizzy and I suddenly stand up when I was sitting. That will be the only presenting complaint, change in position, suddenly change in position. Concern, no concern. DDs, I will go into non-medical and medical quickly. You don't need to ask about everything, just the non-medical, slipping, tripping, lightning, all negative. Alcohol, did anybody push you, all negative. When you go to the positive, loss of consciousness, you don't need the negative. You can say any problem in your ears, no doctor, and that's it, because you don't need to ask all differentials in all cases. As I mentioned, you need maximum 5 differentials. 4, 5 differentials max. So you don't need to ask all of this. But logically, ask about the non-medical causes of fall. Then when you go to the medical causes of fall, postural hypotension, which is the patient will give you change in position before the fall. Now, when you go to P2, you will ask any medical condition. Have you had this fall before? No. Any medical condition, the patient will say, yes, doctor, I have high blood pressure. Whenever the patient gives you finding, what to do? Explore. Tell me more about it. Is it managed? Is it under control? Do you go for the follow-up? The patient will say, I have not been following up, doctor, for quite few months. Is there any reason? No, I'm quite busy. Then P3, smoking and the alcohol, negative. Then when you go to Maftosa, are you on any medication? The patient will give you, yes, I am on medication. If the patient gives you any yes in the history, whenever you take in history and the patient say yes, what to do, explore in detail. What medication are you on? Bendroflumethiazide. Are you taking it as it was prescribed? Yes, doctor, I am taking it as it was prescribed for my blood pressure. For how long? Quite some time. Now, that's another positive finding, which is the patient is on bendroflumethiazide. When you go to examination, verbalize that you will measure the blood pressure lying and standing. When you go to provisional diagnosis, tell the patient the condition is postural hypotension. What is postural hypotension, doctor? It is a condition on your blood pressure where the blood pressure will tend to fall when you change a position. Whenever you change a position suddenly, the blood pressure will tend to fall. Doctor, I'm suspecting this. Why am I having this, doctor? Well, I'm suspecting it. Maybe it's because of you being on medication. Then here, because the patient is on medication, you can open the BNF. What is the BNF? It's a medication book, like what we have back home. Open it, check for the bendroflumethiazide, look for the side effect, and you will see that there is postural hypotension. If you don't have time to open the BNF, say, ideally, I should open the book, the medication book, to check for the side effect of the medication. Now, management of postural hypotension. Postural hypotension, guys, we don't send them home. Dr. Mo, why do we admit them? To exclude other causes of fall. So 7 steps of management. This patient will be admitted. I will be talking to my senior. I will run investigations, as I told you, all blood mainly, full blood count, thyroid, blood sugar, ECG, heart tracing, and then mainly in this case, review medication. Bendroflumethiazide will stop. Will change the medication into some other medication. I will advise my patient to drink plenty of fluid. Drink plenty of fluid. Eat small meals. Eat small meals. And I will mainly advise about posture. How to advise about posture. When you get out of bed, please try to get out gradually, slowly. Don't get out of bed suddenly, number 1. When you are sitting, don't stand suddenly, number 2. So gradually get up. Gradually get up. Number 3, when you first wake up in the morning, cross and uncross your leg firmly before you get up. Guys, when you cross and uncross your leg, it's to increase the blood supply or the blood flow to the brain. Okay, avoid standing for long period. Avoid standing for long period. Yes, okay. And always safety netting. If this continues, come back right away. Next case is a fall due to AF. A fall due to AF. How can I help you? Doctor, I had a fall. Can you please tell me more about it? Tell me more about the fall. Before, during, after. The patient will only give you positive finding, heart racing. My heart is beating fast, or I can hear my heart beating fast. That's the only positive finding. Concern, DDs. When you go to DDs, non-medical, all negative. Medical. When you go to positive, loss of consciousness, onto hypoglycemia, postural hypotension, negative. When you go to the heart, the patient will tell you, yes, doctor, I have heart problem. I feel my heart racing, my heart is beating fast. When you go to P2, the patient will have heart problem like AF, he will give you positive finding. When you go to P3, alcohol smoking, negative, Maftosa. When you ask about the medication, yes, doctor, I'm not using my medication as it was prescribed. He's not. Examination, examine the heart and lung, which is like chest for the heart, and observation. When you go to investigation, provisional diagnosis, it is the AF, it is the heart racing. When you go to management, this patient will be referred to cardiologist. Ask him to use his medication as it was prescribed. Cardiology referral to do further investigation like echo, and ECG will be done, blood will be done, heart attack markers, thyroid function test, blood sugar, full blood count, exactly like that bloods that I mentioned. Okay. Now, the opposite of this station is Stock-Adams syndrome. Stock-Adams syndrome. Stock-Adams syndrome. Stock-Adams syndrome is low heartbeat. So 70 years old, fell at home few days ago, was brought to the A&E. She was diagnosed fractured neck of femur because of the fall. Okay? Talk to her, assess her to find the cause of the fall. What is the question here? Cause of the fall. How can I help you? Doctor, I had a fall. I had a fall. Can you please explain to me more about the fall? Before, during, after. How did it happen? She will tell you, doctor, I was fine. I was sitting with my partner standing in the kitchen, doing some things, and suddenly I fell. Okay, so she will say to you, I suddenly went pale. So that's the only positive finding. Suddenly went pale. Suddenly went pale. Then I had a fall. Okay, then ask about the medical causes, all negative. The medical causes, all negative. Okay, apart from the patient is having or has been treated for heart problem. Then when you go to medical conditions, heart problem, they say negative. Then when you go to family history, she will tell you in family history in Meftosa, family history of heart problems. Then when you examine as I mentioned, observation in everyone, heart in everyone, provisional diagnosis. When you examine the heart, you will be giving that the heart rate is low, you will be giving that the heart rate is like 55, 50, something like this. Then you will give provisional diagnosis that from the information you're giving me, according to my examination, I'm suspecting a condition in your heart where the heart rate is very low and the heart stops momentarily. So the heart stops, the heartbeat stops momentarily, or the heart rate is low. Then when you go to management, you will do all the steps, 7 steps, mainly in investigation, all blood, heart attack markers, full blood count, thyroid function test, blood sugar, and when you go to ECG, heart racing ECG, then we can give you some medication. Medication will be isoprenaline or epinephrine. Refer to cardiologist, heart specialist, because she will need pacemaker and she will need further investigation like echo. Okay, further investigations like echo. Then safety in the patient. That's the Stoke-Adams syndrome. So we said the Stoke-Adams syndrome, we said the AF, and we said the cause of the fall, the first cause of the fall, which is hypoglycemia and postural hypotension. Okay, now let's talk about the medical causes of the fall, which is things not to do with the loss of consciousness. So I will give you some stations about medical causes, negative loss of consciousness. Negative loss of consciousness, I will talk about the ear, 3 conditions: benign paroxysmal positional vertigo, Meniere's vestibular neuritis. Benign paroxysmal positional vertigo, Meniere's vestibular neuritis. Don't forget the core of the station. All of them will come with what? Fall. All of them will come with what? Fall or dizziness. Okay, don't forget, because these are all causes of fall. So when the patient comes with fall, explore before, during, after. When you explore before, during, after, let's talk about every and each station of this, what will be the presentation. So they will all fall under the category of fall. I will follow the same structure, but I will give you the specific presentation about BPPV, Meniere's vestibular neuritis, and the difference between the 3 of them, okay? Benign, paroxysmal, positional, vertigo. Vestibular neuritis, Meniere, and I will add at the end acoustic neuroma. Okay? So benign paroxysmal positional vertigo, vestibular neuritis, Meniere. Number 1, I will compare between the 3 of them according to the presentation. In this case, the patient will tell you, doctor, benign paroxysmal position due to position, vertigo. So it's a vertigo due to position, paroxysmal, sudden change in position, which is the position of the head. So the benign paroxysmal positional vertigo, in the history, the patient will come with a fall, and in the history, the patient will say to you, doctor, I suddenly changed my head position. So the trigger is sudden change in head position, okay? Suddenly change in head position. This is the trigger, suddenly change in head position. What is the trigger for, or what will be the presenting complaint for vestibular neuritis? Again, it's a fall. But what will the patient say to you? Viral infection, 3 weeks before. So this patient will tell you that he had or she had viral infection 2-3 weeks before, flu-like symptoms. Here, sudden change in position. Meniere. Meniere is DVT. DVT, Dr. Mo? Yes, DVT, guys. DVT in the ears. Is there DVT in the ears? No, it's not DVT in the ears. The presentation of Meniere will be deafness, vertigo, and tinnitus. So tinnitus, vertigo, deafness. The patient will have deafness. The patient will have vertigo, which is fall, which is dizzy. The patient will have tinnitus. Tinnitus is, doctor, sounds on my ear. I hear sounds, noisy sounds on my ear. So that's DVT. I think that's a very clear differentiation. DVT, Meniere. Viral infection that led to all of them vertigo, all of them dizziness, all of them fall. But how do I differentiate? Triggered by viral infection or flu-like symptoms, vestibular neuritis. Triggered by sudden change in the position of the head, benign paroxysmal positional vertigo. Okay. In the benign paroxysmal positional vertigo, the patient will tell you that the vertigo or the dizziness lasts for few seconds or minutes. So that lasts for few seconds or minutes. Few seconds or minutes. Few seconds or minutes. What about the vestibular neuritis? Vestibular neuritis, hours. Vestibular neuritis, hours. Vestibular neuritis, hours. What about the Meniere? More than 20 minutes. So, seconds, benign paroxysmal positional vertigo. Hours, vestibular neuritis. Hour, vestibular. Meniere, 20 minutes. More than 20 minutes, okay? Now, let's come to associated symptoms. What do you mean associated symptoms? Like in the benign paroxysmal positional vertigo, the patient will come with nausea but no vomiting. What do you mean, Dr. Mo? Not only he's feeling dizzy and vertigo, but when you open the cubicle into this patient, she or he will have bowl and they want to vomit, but they don't vomit. So nausea, nauseated but no vomiting. Nauseated but no vomiting. Nauseated but no vomiting. They don't vomit, but they feel like vomiting. Okay? So nauseated but no vomiting. Nauseated but no vomiting. Okay? What about the associated symptoms with Meniere? I said to you, the associated symptom, not only dizziness, not only vertigo, but deafness and vertigo, which is the dizzy, and tinnitus. Tinnitus is hissing sounds in the ear. So any problems with ear, deafness, vertigo, tinnitus, we know it's a Meniere. If it's nauseated but no vomiting, we know it is BBV. What about vestibular neuritis mix? Mix. Because it's in the middle, mix. What do you mean, Dr. Mo? Mix means nauseated and vomiting. So this patient, they nauseate, not only that, but vomit as well. Vomit. Why do I say it's a mix of Meniere as well? Because they will have some hearing loss. Hearing loss. Hearing loss. So, vestibular neuritis is a mix in terms of the associated symptoms, is a mix of hearing loss and nauseated and vomiting. This is a clear differentiation between the three of them. Anyway, in Meniere, be careful because it will be bilateral. Meniere is bilateral DVT. Dr. Mo, what do you mean bilateral DVT? Dizziness, vertigo, tinnitus is in both ears. Okay? Acoustic neuroma, which is simply is a cause of vertigo or is a cause of dizziness as well in the ear. What is that acoustic neuroma? It's a benign tumor. Benign tumor in the nerve. Okay, cells that can cause compression. In the surrounding. Okay, so acoustic neuroma from the name neuroma, benign tumor in the nerves. Benign tumor in the nerves. Which nerve? Vestibular nerve. Okay. Anyway, so acoustic neuroma, again, it's a cause of DVT. sorry, it's a cause of vertigo, it's a cause of fall, but again, it is DVT. Allah, Dr. Mo, acoustic neuroma DVT and Meniere DVT. So you mean that acoustic neuroma, the patient will have deafness? Yes. The patient will have vertigo? Yes. The patient will have tinnitus? Aywa. So deafness, vertigo, tinnitus. Deafness, vertigo, tinnitus. Yeah, the patient will have the DVT. But what is the difference between acoustic neuroma and the Meniere? Meniere is bilateral. Acoustic neuroma is unilateral. Unilateral, doctor? One ear? Yes, one ear only. What else? And it will have facial weakness. Facial weakness associated. Why? Because it's in the nerve. It causes compression on the facial nerve and causes facial weakness. That's the acoustic neuroma. So, acoustic neuroma, facial weakness. Okay? So, these are the 4 symptoms. These are the peripheral causes, as I mentioned, positive and negative. Negative loss of consciousness, I said in the negative. Problems in the ears, problems in the head. And in the head, I said stroke, mini stroke, ataxia, but we don't have any cases for the stroke and the mini stroke and the ataxia. We only have these cases, BBBV, vestibular neuritis, Meniere acoustic neuroma, okay? So BBBV, 25 years old, brought to the emergency department with a complaint of vertigo. How can I help you? Doctor, I'm feeling dizzy. When you open the cubicle, I started now the case of BBBV. When you open the cubicle, the patient will have a ball. Wanna vomit, but they don't vomit. They feel nauseated. They wanna vomit, but they don't vomit. So how can I help you? Doctor, I feel that I wanna vomit. Have you vomited? No. What else? Doctor, dizzy. I feel dizzy, which is vertigo. So that's the complaint. Dizzy, vertigo, nauseated. Okay? When you explore the dizziness, when did it start? How did it start? Explore, the patient will say, doctor, I felt dizzy when I was suddenly, looking at my friend, when I suddenly changed my head, trigger, sudden change in head and position, sudden change in the head position. Anything that makes it worse, when I suddenly change my head. Anything that makes it better, I don't know, doctor. Do you have any idea what might have triggered it? Doctor, it was triggered when I suddenly changed my head position. Anything else? Nauseated. Concern? No concern. Differential diagnosis of fall, you will take everything, slipping, tripping, whatever. If the patient had a fall because of the dizziness, if the patient didn't have a fall because of the dizziness, you will ask about all causes of dizziness. All causes of dizziness except the non-medical causes. Oh, non-medical causes, yes. Why? Because in this benign paroxysmal positional vertigo, the patient is feeling dizzy, but no fall. So when you go to the differentials, I have non-medical and medical. In the medical, loss of consciousness and no loss of consciousness. What about the non-medical, slipping, tripping? But in these cases, the patient did not have a fall. So when the patient say, I feel dizzy, if you ask them, did you have a fall? No. So no fall. So you will ask about the medical causes, positive and negative loss of consciousness, but not about the non-medical cause. Because the non-medical causes, slipping, tripping, alcohol, pushing, all this can lead to fall. All these causes of fall. So the causes of fall, non-medical and medical. The causes of dizziness only. No fall. It's just the medical. Okay? So this case, the patient did not have a fall. So no need to ask about the non-medical. Ask only about the medical. Okay? Then exclude positive loss of consciousness, negative loss of consciousness. And the strongest question, did you lose consciousness? When you exclude positive and negative loss of consciousness, positive loss of consciousness, we know hypoglycemia, hypotension, heart rate high, heart rate low, epilepsy, and vasovagal syncope, all negative. Then when you go to the peripheral or the other causes, negative loss of consciousness, the patient will give you the sudden change in position of the head. DESA, not relevant. Maftosa, any medications, are you on any medication quickly? So DESA is not relevant. Then examination, observation, and you need to verbalize that you examine the ear. Do you examine in this case? No, just a verbalize examination. What are the examination that you will verbalize? You will do Dex Hallbeck test and you will do Romberg test. Verbalize. Do I need to do them, Dr. Mo? No. you will verbalize Dix-Hellberg test and Romberg test. Provisional diagnosis, you will tell the patient from the name of your condition, benign, paroxysmal, positional vertigo. Benign, which means that it's not serious. Paroxysmal, which means it comes in episodes. Positional, which means triggered by the sudden change in position of the head. Vertigo, which means dizziness. So you're gonna explain it from the name of it. Benign, not serious. Paroxysmal, episode. Positional, change of head position, vertigo, dizziness. Doctor, why did I have this problem, or why did this happen to me? You will say, well, our inner ear is a fluid-filled structure called semicircular canals. It has fluid inside that should be clear. In your condition, there is a bony fragment in this fluid, or in this structure that literally when you change your head, when you suddenly change your head, this bony fragment causes trigger for this vertigo. Okay? Management, nothing. Senior, no admission, yeah? No admission, yeah? Senior, any investigations needed? No. No investigations needed to diagnose the condition. So step 1, admit? No. Step 2, senior? Yes. Step 3, no investigations needed. Step 4, lifestyle. No investigation? Yes, I will tell you now. No investigation, but maybe later we will need investigation, CT scan, but I will tell you when. So at first, presentation, no investigation. Treatment is mainly lifestyle. Mainly lifestyle, okay? So many things that you do to ease the symptoms and reduce the episode that you will have. What are they? What is the cause? Suddenly change in the position of the head. So the first main lifestyle thing that you do, move your head carefully, slowly during your daily activity. Okay. Sit down straight when you feel dizzy. Whenever you feel dizzy, sit down straight. Don't sit like this, sit down straight, okay? Sleep with your head slightly raised in 2 or more pillows. So your head should be raised in 2 or more pillows, okay? Try to relax, as the anxiety can make the vertigo worse. So try to relax. Lie still in a little quiet dark room to reduce the spinning. Whenever you have the vertigo, you can lie in a room that is quite dark and quiet to decrease the symptoms. These are lifestyle things that you will do. It is self-limited, resolves on its own. However, we can give him antihistamine, buccal prochlorperazine. So antihistamine, buccal prochlorperazine, some medication. Antihistamine, buccal prochlorperazine. So what is the management? 2 medications, antihistamine, buccal prochlorperazine, plus you can give them even cyclizine for the nauseated feeling. You give them, you do the lifestyle. When you have the dizziness or the vertigo, sit in a quiet dark room. Try to not suddenly change your head, slowly and gradually, things like this, lifestyle modification, okay? Then, do we refer? Step 5, yes, we do refer if the symptoms persist to ear specialist who will do CT and MRI. One thing not to forget in safety netting, DVLA. So every single patient, DVLA. So do not forget DVLA in every single patient with vertigo. Second is vestibular neuritis. Say, how can I help you? Doctor, I'm feeling dizzy. I said to you, vestibular, BBV, Meniere, acoustic. It is the non-medical or the medical? The medical causes of fall, not the non-medical. So I have the fall, medical and non-medical, but the dizziness, only the non-medical. Because the dizziness, maybe they did not have a fall. So then you don't ask the medical causes, the non-medical causes, which is sleeping, tripping, you don't need to, as long as no fall. 25 years old, came complaining of dizziness. Same, how can I help you? Doctor, I feel dizzy. Explore for how long did the dizziness last. Tell me more about it. What do you think might have triggered it? Any sudden change in head? No. Anything else? No. When you ask her, she will tell you, I had flu-like symptoms 3 weeks before, or viral. So viral infection or flu-like symptoms 3 weeks ago, and it lasts for hours, this dizziness, and the patient may give you, I vomited, I feel nauseated, okay? Okay, and maybe some hearing loss, all right? Okay, now professional diagnosis, a condition of your inner ear, because all this inner ear, because the inner ear is responsible for balance. So all these cases are inner ear, balance. A condition in your inner ear in which neuritis, inflammation in the nerve, in the nerve that connects or that innervate the inner ear or that connect the inner ear to the brain. So a condition in the inner ear in which there is an inflammation in the nerve that connect the brain to the inner ear. All right, management, guys, same or similar to BBV. Management, admission, no, go home. Senior, yes. Investigations needed, no investigations needed. Is it self-limiting condition? Self-limiting condition. It will go on its own. No investigation unless it persists. Okay, so no investigations needed. Self-limited goes on its own within 6 weeks. What medication do you give and what lifestyle do you give? Medication, again, antihistamine, prochlorperazine. You can give cyclizine. Take any medication for sickness. Okay, so antihistamine, prochlorperazine, cyclizine. Okay, what else? Lifestyle. Like what? Plenty of fluid, bed rest, avoid becoming dehydrated. So bed rest, plenty of fluids, avoid becoming dehydrated. Okay, how can I minimize the feeling of dizziness? Again, avoid the bright lights like the BBBV, dark quiet rooms, avoid noise, avoid drinking too much alcohol. Then you refer to specialist ENT for CT and MRI if the symptoms persist. Safety netting, again, warning sign, again, DVLA. Meniere, same. How can I help you? Doctor, I'm dizzy. I feel dizzy. Explore. For how long does dizziness last? More than 20 minutes, doctor. Apart from dizziness, anything else, doctor? Hearing loss. Which ear? Both ears, doctor. Anything else? Tinnitus. Which ears? Both ears, doctor. Okay? However, be careful because it's bilateral, but recently they brought it in the exam unilateral. How do I differentiate, doctor? Because you said acoustic neuroma is unilateral DVT, Meniere bilateral DVT. How do I differentiate? If there is no facial weakness and facial pain, it's Meniere. So if there is no facial weakness and facial pain, it's Meniere. Anyway, when you explore the other symptoms, when you go to the causes, again, is it medical or non-medical or both? Only the medical, because the non-medical is false. So only the medical causes I will ask. Everything is negative apart from DVT, deafness, vertigo, tinnitus. Okay, and examination, examine the ear and verbalize the observation. Management, again, this patient in this case will need to be referred to ENT specialist. Okay, so Meniere referral to ENT specialist. All right, that's it. This is the cases of falls, okay, all of them, and all the cases of dizziness. All right, thank you very much. Thank you.